This morning, we're excited to have Dr. Virginia Pitzer here with us, who is an associate professor of epidemiology at the Yale School of Public Health. She earned her doctorate in epidemiology from Harvard School of Public Health, and then was a postdoctoral research fellow at Princeton and Fogarty International Center of the NIH as part of the Research and Policy for Infectious Disease Dynamics program, which is denoted RAPID. Her lab is primarily focused on the transmission dynamics of enteric diseases like rotavirus and typhoid, but they use mathematical models to examine the underlying patterns of diseases for a number of different diseases. And in fact, really her innovative studies to understand the environmental drivers of respiratory diseases like RSV and flu were how I first ran across her research. And influenced much of my thinking for some of my dissertation. So as many of us did though, her research switched gears for the COVID-19 pandemic. And we're really excited to have her here this morning to discuss herd immunity, which I think is a topic on all of our minds right now.
Great, well, thanks for the introduction and the invitation to come speak to you guys today. Let me share my screen here. Okay. Hopefully you all can see my presentation now. So as Spencer said, I'm going to be talking about just some recent thoughts and some very, very preliminary kind of work in progress that we're doing around herd immunity and COVID-19 and specifically looking at some vaccine effectiveness estimates against infection and infectiousness. And so just kind of to start, one of the things I want to do is to talk about what we actually mean when we say herd immunity. I think that term is being used a lot, both by modelers and epidemiologists, as well as in the press. And if it's often used to mean different things in a slightly different way. And I just, want to clear up a little bit of the confusion about kind of what I mean when I say herd immunity and kind of how we think about herd immunity. And then I'm going to talk a bit more about one of the big sources of uncertainty in the herd immunity threshold, or the fraction of individuals that need to be immunized in order to completely eliminate transmission from the population, including uncertainty in R0, uncertainty in the duration and levels of immunity, both from vaccination as well as from previous infections. But really what I want to focus on most of my talk today is on uncertainty in vaccine effectiveness and the components of vaccine effectiveness that go into that calculation. And discussing kind of how we can hopefully try and start to resolve some of those uncertainties. And so this is a figure that Mark Lipsitch, who was my PhD advisor, gave me when I was starting to teach my course that I find kind of very useful in terms of illustrating the concept of herd immunity, where if we have infection with an R0 of 4 and no vaccination in the population, then on average, we expect one person to infect 4 other people, and each of these 4 other people to infect 4 other of their contacts. And so now if we vaccinate 75% of the population, the vaccinated individuals who are protected are in gray, and the unimmunized individuals are in black here. And so now the gray individuals are protected, only that one unimmunized individual gets infected, and only their unvaccinated or unprotected contact gets infected, whereas these 3 other contacts also remain uninfected, even though they're unvaccinated or unprotected, because they weren't exposed to that person who would have infected them otherwise. And so when people say herd immunity, in general, I think what this should refer to is just the idea of indirect protection, or the reduction in risk that occurs for unvaccinated individuals because there is less transmission happening in general within the community. And this depends on the vaccine coverage, it depends on the vaccine effectiveness against transmission, and it depends on the population structure and contact network in general. Other individuals, since I work a lot on enteric vaccines, people think of the actual shedding of live attenuated pathogen by vaccinated individuals, for example, which happens with the oral polio vaccine, and also can happen with like the flu mist vaccine, for example. But really, I think this should be relegated to the idea of contact immunity and the sort of contact actual transmission of vaccine that can happen within the population. And then finally, I think, particularly in the press now and the way it's been used, herd immunity is really being used to refer to the level of immunity in the population that is needed to interrupt transmission completely and to bring the effective reproductive number below 1 such that it stays below 1 and that the infection is eventually eliminated from the population. And this comes from the concept of the critical proportion to vaccinate, or what I'm going to call the PC here, where in order to eliminate the pathogen, you must reduce the effective reproductive number to below 1 and keep it below 1. We can do a simple calculation back of the envelope to get what that threshold is by setting the R0 times the proportion of individuals who remain susceptible, or 1 minus the PC, less than or equal to 1, solve for PC, and we get the herd immunity threshold, or the critical proportion to vaccinate, of 1 minus 1 over R0. But it's really important to remember what this PC represents is not the vaccine coverage, but rather the portion of the population that must be effectively immunized, where it's the proportion of the coverage that has been vaccinated, or the vaccine coverage times the vaccine efficacy against transmission. And so if we just plot out this relationship of 1 minus 1 over R0 for different values of R0 from 1 up to 25 here in this plot, and we suppose that our R0 for COVID-19, or the SARS-CoV-2 virus, is somewhere between 2.5 and 3, then this back of the envelope calculation gives us a critical proportion to immunize of between 60 and 67%, which was kind of this idea that was thrown around a lot, I think, early in the pandemic of this is the proportion of people we need to vaccinate. But of course, that is just the proportion that would need to be vaccinated. If we assume here the PC is actually equal to the vaccine efficacy times the coverage, then the coverage is equal to that proportion divided by, say, 95% efficacy for the Pfizer vaccine, giving us a coverage of 63 to 70%. But that 95% value isn't the right value to be using here. Really, what we need to be using is the vaccine efficacy against infection in general, or infection and transmission. There was a study that came out of CDC a month or two ago suggesting that when they tested healthcare workers routinely for COVID-19, both symptomatic and asymptomatic infections, they're getting a vaccine effectiveness estimate for the Pfizer and Moderna vaccines of around 90%, this giving us a coverage of now 70 to 78% to achieve that herd immunity threshold. Now along come the variants. The variants we believe are around 1.5 to slightly more transmissible than the original virus, for which we estimated the R0 being 2.5 to 3. So we multiply 2.5 to 3 by around 1.5. All of a sudden, our R0 is now 4 to 5. If we consider the fact that these variants are really becoming the dominant strain of the virus that's circulating in the population. And there's also evidence to suggest that the vaccine effectiveness is slightly lower against these variants. And so if we lower our vaccine effectiveness against infection and transmission with these variants to something around 80%, all of a sudden now we need to achieve 94% to 100% coverage of the population in order to interrupt transmission completely and eliminate the infection. And so this is why I think, there's a lot of talk now about whether or not that herd immunity is really, as it referred to as the sort of achieving elimination, is something that's actually feasible to achieve within the population. And so one of the key components here, and one of those key inputs, is that vaccine effectiveness. And it's not the vaccine effectiveness against symptomatic disease, which has been measured in the trials and is measured most generally, but really it's the vaccine effectiveness against transmission. which is a function of both the vaccine effectiveness against infection with the SARS-CoV-2 virus in the first place, both symptomatic and asymptomatic infections, which I'm going to refer to as the VES here, as well as the vaccine efficacy against infectiousness given infection, which I'm going to refer to as the VEI, such that the total vaccine effectiveness against transmission is going to be equal to 1 minus the VES times 1 minus the VEI. So the reduction in risk of infection times the reduction in risk of infectiousness given infection. And so one of the things that we've been working on was using household data from Israel to try and actually tease out some of these estimates of the VES and VEI. And so this is data that's, or work that's really much ongoing, kind of hot off the presses. I think I got some preliminary results yesterday to share with you. So please take all of this with a big grain of salt, but really I want to kind of more go over our approach to what we're doing here to estimate the VES and the VEI. So in terms of the data that we have individual level healthcare record data or healthcare claims data from KSM, which is the research arm of Maccabi, which is the second largest healthcare provider in Israel. And if you believe their logo, is the best healthcare group in Israel. We have limited our period of study to the period where testing has been at least somewhat more consistent within the population. So we're looking at positive PCR tests among individuals and their linked household members from the 1st of June 2020 to the 25th of March of 2021, which is the last date of PCR test that we have in the data set that was provided. This gives us a total number of households in the study period of over 600,000 households. And if we limit those to households that had at least one PCR positive infected individual and at least 2 household members residing in that household to look at the actual sort of risk of transmission and how it's modified by vaccination, this gives us nearly 56,000 households to look at here. And one of the key things that we're doing, given that we only have data on the date of PCR positive or negative tests, one of the things that we need to infer in order to infer transmission is actual timing of infectiousness among individuals within a household. And so to do this, we've used a data augmentation approach, which I'm going to describe here. So for example, if we have a household with 3 members, 2 of whom, in this case, the father and the son here, had a positive test result, and we're going to assume that the mother had a negative test result a day or 2 after the father first tested positive for SARS-CoV-2. For the individuals who have a positive test result, the first thing that we do is to sample from a gamma distribution for the time from onset of infectiousness to testing and receiving a positive test result for each of these positive household members to get a sort of inferred date of onset of infectiousness for each of the individuals within the population, or within the household rather. For these individuals, we then sample from a distribution for the infectious period to get the end of the infectious period for each of these positive individuals within the household. And we sample from a distribution for the latent period to get a timing at which the individual actually was infected within the household. And then we use this data to infer sources of infection within the various household members here, where as a sort of simple example of this data, we assume that the father must have been infected from outside the household, which we're going to call an exogenous source of infection from the community, whereas the son may have been infected possibly by the father on his first day of infectiousness, or possibly from outside of the household. And then we assume that the mother escaped infection from both outside the household as well as from these infectious household members during the entire course of their infectious period. And we can't just sample, obviously, a single realization of each of these different delay distributions for each household, but rather we need to sample, many, many times from these possible delay distributions to get these possible realizations of what the actual infection history within each household might be. So for each sample, we sample from these independent gamma distributions for the time from onset infectiousness to a positive test, from the infectious period as well as from the latent period, to get the sort of realization of infection within the household, estimate all of our model parameters, and then do it all again for up to, we haven't figured out the exact number of samples that we're going to need, but in terms of computational feasibility and balanced with kind of the need to fully describe the uncertainty, we're aiming for around 1,000 samples from these different delay distributions. In terms of the actual data structure that is inputting our model, the main output that we are fitting to is our augmented data on the days in which an individual is been infected, which we're going to call YIJT for individual J in household I at time T, where Y is 1 if the individual was infected. It's NA if that individual was previously infected and is now immune to future infection, and 0 otherwise. And then we follow infected individuals from time 1 being June 1st to the day at which they were infected, and all uninfected individuals contribute person time to follow up from day 1 to the end of the study on March 25th. And again, so just an example with a single household with 3 people, 2 of whom were infected. This one person may have been infected, say, on the first day of follow-up and is NA afterwards. The second person contributes 0 up until the time that they were infected and is NA afterwards. And then the third person's would be 0 kind of throughout the study period. So ideally, what we want to do in order to describe this model is to use a household transmission model in which for a given person J in household I, the probability that of their observed or augmented outcome YIJT, given a probability of infection at time T for individual J in household I, is going to be Bernoulli distributed with this probability pi, where this probability of being infected at any time T is going to be equal to 1 minus the probability of escaping infection from outside the household, as well as from all infected household members during their infectious period, which is what's being described by this product here, from K equals 0 being the risk of transmission from outside the household, and K not being equal to J up to the number of household members in household I, where it's 1 minus the probability of transmission from individual K to individual J raised to this dkj power at time T, which is an indicator function that individual K can transmit to individual J on day D. So this is going to be 1 if the individual K has started their infectious period before time T and has yet to either reach the end of the infectious period of individual K or the time at which individual J got infected. And if the individual is not infectious or not exposed to an infectious individual, this D is 0. And so the probability of escaping infection from all household members and from the community is just going to be 1 minus this product, or the product across all the community risk and all potentially infectious other household members. So the key kind of part of this model in which we can incorporate risk factors for transmission is in our PKJ estimates, where the exogenous risk of transmission or probability of transmission coming from outside the community each day is described by this P0J. And we model it as a logistic regression relationship where it's a function of this delta 0, which is the baseline risk of transmission from the community. Also a function of the number of potentially positive tests occurring within the whole database, or essentially the incidence rate of positive COVID-19 cases throughout the HMO database, sort of being an indication of the time varying component to risk from the community, plus beta 2 times a coefficient here for whether or not the individual is fully vaccinated. And right now we're just incorporating kind of having received at least 2 doses of the vaccine, being defined as being fully vaccinated. Plus 2 indicator functions for the age group. So we divide the population into under 10, 10 to 60, and 60 plus, and estimate relative risk coefficients for the 10 to 60 and the 60 plus age groups compared to the under 10s. Whereas the endogenous risk of infection from an infected household member, which is our PKJ here, is going to be a logistic function of the baseline risk of infection within the household, kind of also sort of an estimate of the daily secondary attack rate, plus the vaccine effectiveness, or this beta times the vaccination status of individual J, plus the vaccination status of individual K here times kappa 2, and again, plus the age group of our the individual J. And so in order to calculate the vaccine effectiveness estimates, we can extract from this model both the vaccine effectiveness against susceptibility from this beta 2 coefficient of the vaccination status of individual J, where the vaccine effectiveness against susceptibility is 1 minus e to the beta 2 estimate, whereas the vaccine effectiveness against infectiousness here is going to be 1 minus the exponentiated value of the kappa 2, or the probability of transmission from an infected but vaccinated household member. And then the overall likelihood function ends up being a product across all of the households in our database, which again was around 56,000 households. All of the individuals who are members of this household for 1 to NHHI, and then from all of our time points from 1 to the end of follow-up of the study, where the probability of each individual's observed outcome at time t is a function of this probability of escaping infection at time t, such that it's essentially the product is the product across the probability they escaped infection raised to their observed outcome. So the contribution of any uninfected individual is just the probability that they escaped infection at all time points from the beginning of the study to the end of the study. So 1 minus pi ij for all time points, which is just going to be the product across all the time points and all of the household members who they were potentially exposed to during this time point, 1 minus the probability of transmission during that day, raised the probability that they were exposed to an infectious household member during that day. Whereas the likelihood contribution of any infected individual, where their time of infection sampled from these delay distributions is TJ, is going to be the probability that they escaped infection up to time TJ minus 1 here, which is the probability of all time points from T1 to TJ minus 1, times their exposure to all of the household members at that time, times 1 minus the probability of transmission from that household member, raised to the what exponent of whether or not that household member was infectious, times the probability that they did not escape infection on this particular day, TJ, in which they got infected. And so again, you're going to have potential risk from inside the household as well as risk from outside the household. So far we've had issues with getting this model to converge. It also takes a long time to run, so we've run into some computational issues. One of the issues being with this, I think, exponent for trying to incorporate the time varying risk. We have some very, very preliminary estimates, but I'm just not quite sure I believe them just yet. Preliminary estimates being around 82% vaccine effectiveness against susceptibility and around 54% vaccine effectiveness against infectiousness. But again, I think we need, for one, many more samples from the delay distribution to confirm this, and sort of more tests to make sure that it's not kind of being too reliant on how we initialize the model. So in the meantime, we've kind of taken a sensitivity analysis, fit a kind of simpler GLM or generalized linear model based approach to estimating these household risks in order to kind of have a way of comparing our results that we get from this transmission model to another model that doesn't formally account for transmission happening within the household. And so for this model, we're assuming each individual's outcome, again, is Bernoulli distributed with a probability equal to the risk of transmission happening to that individual at each time point. But here we're modeling this pi ijt using a log minus log relationship of the risk of transmission occurring as a function of that individual's personal vaccination status, which is represented by B2 here and modified by the coefficient theta, plus a function of whether or not there are other unvaccinated infectious individuals in the household at time t, modified by this eta 0, plus whether or not there's any vaccinated infectious individuals at time t, modified by zeta 0, plus an indicator, an interaction term here of the vaccination status of individual J and the vaccination status of the other household members, or rather presence of another unvaccinated infectious household member or vaccinated infectious household member with these two interaction terms. And then again, indicator functions for the susceptibility based on the age group of individual J, and a flexible spline for the baseline hazard infection at calendar time t. So we've had a little more success in getting this model to run and getting some preliminary results, which I'm going to share with you now, where we can estimate the vaccine effectiveness against susceptibility to infection from these various exponents, in particular, the theta exponent gives you a measure of the effective vaccination, assuming there are no infected household members that the individual has been exposed to. So only kind of risk of transmission happening from outside the household member, outside the household, if M2 and Z2 are 0 at all time points. And this gives us a vaccine effectiveness estimate of 88% against infection. If M2 is non-zero and an individual has been exposed to infected unvaccinated household member, then we're getting a vaccine effectiveness estimate that's a function of both theta and eta 1, or a vaccine effectiveness estimate of 93%. Whereas if the individual has been exposed to an infected vaccinated household member, we're getting a slightly lower vaccine effectiveness estimate of around 71%, which possibly is explained by kind of residual confounding, by age or other factors, or actual effect modification. We're not really sure yet. We can also use these eta and zeta exponents to estimate the relative risk of having infected unvaccinated or vaccinated household member in your household, and finding that if for unvaccinated individuals, your risk goes up, or your hazard ratio is 8.1 if you're exposed to a unvaccinated infected household member, but only increases approximately 5-fold if you're exposed to a vaccinated infected household member. Whereas the effect of having an infected, oh wait, sorry, if you yourself are vaccinated, your risk is only going up 5-fold. Whereas the effect of being infected, having an infected vaccinated household member versus not having an infected household member is has a ratio of 1.5 for unvaccinated individuals and 7.5 for vaccinated individuals. And from these, we can then get an estimate of the vaccine effectiveness against infection, where the effect of having a vaccinated versus unvaccinated infected household member, the ratio of these two effects, given you're unvaccinated, gives a vaccine effectiveness against infection of 82%, whereas the effect of having a vaccinated versus unvaccinated infected household member, if you yourself was vaccinated, is 23%. So again, we got these results yesterday, haven't had a ton of time to kind of dig into them and figure out how to interpret them, but would definitely be happy to kind of talk more about, you know, what does this all mean for the vaccine effectiveness against infection. And then finally, I just wanted to talk a little bit about kind of herd immunity and COVID-19 and how we think about this idea of kind of herd immunity being co-opted early in the pandemic to really meaning getting enough people infected and immune, and ideally kind of only the young and healthy people, such that we brought down the effective reproductive number below 1. I think one of the very dangerous aspects of that was that the effective reproductive number equal to 1 really just corresponds to the point in which the epidemic starts to decline. So you definitely overshoot the proportion of the people that get infected. It's going to be much greater than just that critical proportion that would need to be immunized through vaccination, for example. Furthermore, no pathogen has ever really been eliminated or eradicated through herd immunity from natural infection. The infection has natural dynamics results in the fact that less infected people around means that there's lower risk of infection, and kind of constant replenishment of individuals through births and through waning of immunity is going to maintain risk happening within the population. And so one of the other things that we've done is to try and estimate the numbers of new infections through time, accounting for our knowledge of the reporting process and the reporting delays and natural history of disease, in order to allow for more accurate assessments of the impact of interventions. And it's not a transmission model, it's simply a sort of natural history of disease model in order to nowcast infections of COVID-19. And we've been, we created a website, covidestim.org, in order to provide estimates at the county level of the current number of infections estimated to be in the population, both total numbers as well as rates per 100,000, effective reproductive numbers through time based on these current infections, as well as the percent of individuals ever infected. Again, with this map being the percent of individuals ever infected, showing, pretty close to what you might expect for a herd immunity threshold in parts of Arizona, for example. And that's all I wanted to go through today. Just wanted to thank some of the other members of the Public Health Modeling Unit who've been involved in this work, particularly Ottavia Prunas, who's a postdoc who's been working with Dan Weinberger and myself on the vaccine effectiveness estimates, as well as the larger team involved in COVID-ESTIM, and our collaborators from KSM, as well as funding from MIDAS and other NIH grants. So definitely happy to talk more about any of these ideas or other ideas as people like.